Hi everyone, and welcome back to part 2 of our presentation on atrial fibrillation. This week, I saw multiple patients who were diagnosed with atrial fibrillation for the first time and were nervous about the management of their condition. So they had many questions for me, including, can they live a normal life? Which medications will they need? Do they need to be on blood thinners? Are they going to need a procedure? If you recall, in part 1, we spoke about what exactly is atrial fibrillation. Now we want to discuss the management of atrial fibrillation. So, what is the next step after a patient is diagnosed with atrial fibrillation? Now, for the sake of this discussion, I am going to assume after the diagnosis of atrial fibrillation, multiple blood tests were done, cardiac testing was accomplished, and performed by a qualified cardiologist to rule out potential causes of atrial fibrillation. Please check out last week's video for more details on the possible causes of atrial fibrillation at my website, drdavedigadi.com. Once we make a diagnosis of atrial fibrillation and the person has a proper workup by a qualified cardiologist, we need to address two major issues. First, do we need to get this person out of atrial fibrillation and back to normal rhythm? And second, does this person need to be on blood thinners? Let's start with the first issue. Do we need to get the person out of atrial fibrillation? This is best answered by understanding that there are three main types of atrial fibrillation. First, paroxysmal, which means the person goes into atrial fibrillation but then comes back into their normal rhythm. Second, persistent, meaning atrial fibrillation lasts longer than 1 week. And finally, permanent, meaning atrial fibrillation is chronic and the decision is made to leave the person in atrial fibrillation. If a person has atrial fibrillation, they are at risk of having an elevated heart rate well over 100 beats per minute, and this can cause both symptoms and even a weak heart. Most patients who present with atrial fibrillation will require slowing of the heart rate with medicines to improve symptoms. Once we get the heart rate under control, then we need to answer the following. Do we leave the person in atrial fibrillation, or should we try to get them out of it? Studies have shown that patients in atrial fibrillation have similar outcomes whether they are kept in atrial fibrillation or converted back to their regular rhythm. So what are some of the factors that help doctors decide if a person should be returned to their regular rhythm? First, presence of symptoms associated with atrial fibrillation. Some people experience symptoms such as shortness of breath or palpitations that affect their quality of life. Second, development of a weak heart thought to be secondary to the arrhythmia. If a person has symptoms or a weak heart, most doctors would agree that there should be an attempt to abolish the atrial fibrillation. One factor might be age. In younger patients, usually less than 70 years old, the treating doctor may want to try and get the person out of atrial fibrillation, whereas in older patients, we might leave them in atrial fibrillation as long as they are tolerating it and monitored closely. If it is decided to try and get people out of atrial fibrillation, it is usually accomplished with either giving person medicines or cardioverting, also known as shocking the heart back to normal rhythm. Another option is called catheter ablation, where a cardiologist called an electrophysiologist threads a catheter into the heart and tries to either burn or freeze the area where the atrial fibrillation is coming from. So that is the first question. Do we try to get the person out of atrial fibrillation? The second and probably most important part of treating atrial fibrillation is deciding who needs blood thinners, also called anticoagulation. The most feared complication of atrial fibrillation is stroke. Stroke from atrial fibrillation averages 5% a year, which is somewhere between 2 and 7 times the rate of stroke in patients without atrial fibrillation. And when strokes do occur in atrial fibrillation, they are often large and catastrophic, many times creating permanent disability. So how do we decide who should be on blood thinners? First, it should be noted, if you have a history of rheumatic heart disease or valvular surgery, most cardiologists would agree blood thinners will likely be required. But again, this needs to be individualized. But what about the rest of the population with atrial fibrillation? There's a very useful score we use called the CHADS-VASque score. With the CHADS-VASque score, a high score corresponds to a greater risk of stroke, while a lower score corresponds to a lower risk of stroke. The CHADS-VASque score stands for C for congestive heart failure, H for hypertension, A for age, D for diabetes, and V for vascular disease. For each one of the above, your doctor will assign a point with age greater than 75 and stroke getting 2 points. If your score is greater than 2, then typically blood thinners are recommended. In fact, you can go ahead and calculate your own score to see if you would be considered a candidate for blood thinners. Now, I'm not going to go into more detail on the CHADS vascular score because it is something that needs to be individualized. In fact, starting blood thinners is a critical decision that needs to be made between you and your cardiologist. What blood thinners are available for atrial fibrillation? This is a question I am going to review in a future video. But to put it simply, there is warfarin or Coumadin and a newer class of blood thinners called the novel oral anticoagulants, including Eliquis, Xarelto, and Pradaxa. What about aspirin? For many years, doctors, including cardiologists, used aspirin for stroke prevention in atrial fibrillation. But as of this time, the evidence does not support the use of aspirin alone for the prevention of thromboembolic events in patients with atrial fibrillation. Okay, there you have it, the general approach to atrial fibrillation. Stay tuned for a future video speaking more about stroke risk and atrial fibrillation with anticoagulants. Guess what time it is? That's right, it's time for a famous Dr. Dave joke. Doctor says, I have some bad news and some very bad news. Patient, well, might as well give me the bad news first. Doctor, the lab called with your test results. They said you have 24 hours to live. Patient, 24 hours? That's terrible. What could be worse? What's the very bad news? Doctor, I've been trying to reach you since yesterday. The doctor said he would have me on my feet in 2 weeks. And did he? Yes, I had to sell the car to pay for the bill. Okay guys, I'll stick with cardiology. Until next time, this is Dr. Dave.